So we're right here at 2:35. So we're going to go ahead and get started. So welcome everyone. My name is Jenny Winkler, a director at the Illinois Health and Hospital Association. I want to welcome you to our session today around managing common infections in long-term care. We have two incredible speakers today. So before we get started, I'm just going to take a moment to introduce you to Dr. Dumyati and Dr. Katz. So our first presentation this afternoon is going to come from Dr. Dumyati. Dr. Dumyati is an infectious disease physician and a professor of medicine at the University of Rochester Medical Center. She has extensive expertise in prevention of healthcare-associated infections and antibiotic stewardship through several quality improvement collaboratives that focus on reducing the burden of healthcare-associated infections. And Dr. Dumyati is a very active member and plays a key role in multiple professional organizations. Our second presenter this afternoon will be Dr. Morgan Katz. Dr. Katz is an infectious disease faculty member at Johns Hopkins University who's dedicated her academic research career to infection prevention and antibiotic stewardship in long-term care. Dr. Katz has made significant contributions to academic research and has been the lead for several large grants. She's also served on the White House Commission to guide the Centers for Medicare and Medicaid Services on the care of nursing home residents throughout COVID-19, and also plays an active role in education. So with that, I'm going to go ahead and turn things over to Dr. Dumyati to get things started. Thanks.
Thank you for the introduction. You hear me okay?
You sound good.
Okay, good. So I'm going to go over the management of common infection in long-term care. I'm going to use nursing home interchangeably. So my presentation is around 30 minutes, and Morgan Katz is going to do the management of MDRO, and then we'll take the question at the end. So as conflict of interest, I have grant funding from Pfizer. I have the two following objective is to tell you when treatment is needed for common infection syndrome in the nursing home and when they're not needed, and discuss the appropriate treatment of urinary tract infection, pneumonia, and cellulitis. As you're all aware, it's estimated approximately 2.3 to 5.3% of residents have an infection at a certain time. This, translates in 1 in 18 to 1 in 43 residents, and a certain day have an infection. These infections are associated with high mortality and morbidity, rehospitalization, and extended hospital stay and substantial healthcare expenditures. We know this is from a point prevalence survey that was done by the CDC around 163 nursing homes in 2017. That 8.2% of residents are on an antibiotic on a given day. Of those, the majority are for 3 indications, which we call PUS, which is pneumonia, urinary tract infection, and skin. And so they really are the driver of antibiotic use in the nursing home. We know from several studies that many of this use of antibiotic for these indications is either inappropriate or unnecessary. So what do I mean by unnecessary and inappropriate? So it could be unnecessary if you're treating, for example, a positive urine culture when the patient is asymptomatic, i.e., having asymptomatic bacteria, which are discussed in the next slide. Or it could be, treating an upper viral respiratory tract infection with antibiotic, or treating just a positive culture from an ulcer when there is really no clinical evidence of infection. It is inappropriate when, the diagnosis is wrong, the drug used, what you chose is not the correct antibiotic, the correct dose, the correct duration, or you fail to, assess and adjust the antibiotic when your culture is back, and depending on the condition of the resident. So all these things, lead to inappropriate or unnecessary antibiotic use. And then it is, for people, I'm not sure how many of you are from acute care and how many are from nursing homes. The antibiotic decision in the nursing home are much more complicated than in the hospital. And it is due to multiple factors, including the fact that, the medical provider are not there 24 hours to assess the patient. A lot of the care is given by CNA, so they will be probably the first people to identify a change in a condition of a resident. They have to do, call the LPN, the RN to do the assessment. And then there is some communication that's happening with the provider, sometimes over the phone. Sometimes the provider doesn't know the nurse, doesn't trust the nurse. And so all these factors, play a role in the decision that's eventually made. There's also an important factor, which is a family. Sometimes the family would come and say, my mother doesn't look good today. That's how she looks when she has a urinary tract infection. And that might lead, to kind of pursuing a urine culture and, pursuing treatment. So it is complicated, and to assess all these, to improve any of the treatment of patients in the nursing home, you have to really target all these aspect of the treatment decision for antibiotics. And what we know also that in nursing homes, a lot of time a culture or an antibiotic is started because of some non-specific sign and symptom, maybe a fall, maybe some confusion. And recently a document was published by Dr. Rowe, who looked at all the reliability of non-specific signs and symptoms as indicator for the presence of infection, because they really drive a lot of the antibiotic use, specifically the one that are on the right side, where a behavioral change alone, functional decline, a fall, or anorexia trigger kind of a cultures or evaluation for infection, and it might not be necessary. And you could see what is necessary, when could it be a potential infection, is more concrete findings such as fever, hypothermia, hypotension, hyperglycemia, and delirium. So it might be a document that is worth checking to help, kind of know when someone should be evaluated for a potential infection and when someone should be just monitored and watched. So I'm going to start with urinary tract infection, which really is the most common indication for antibiotic use in the nursing home. It's the most common reason for bacteremia in the nursing homes. And it's the most common reason, though, for inappropriate antibiotic. And usually it's commonly inappropriate because we treat asymptomatic bacteriuria, or we give prolonged UTI prophylaxis, which is really not indicated in the population of the resident of the nursing home. So what is a asymptomatic bacteria and what's a UTI? A UTI is really truly a clinical diagnosis. It requires a positive culture or a urinalysis plus signs and symptoms that are localized to the urinary tract, and it could be with or without fever. So if you have someone that, for example, was confused, you got a urine culture, and the urine culture is positive, or the urinalysis shows pyuria, and you decide that it's a urinary tract infection, but the person really has no urine symptoms, no dysuria, no frequency, no urgency, no hematuria, and no fever, this person probably is just colonized, which is very common colonization of the urine in this population. It's in women is 20 to 50%, in men is 15 to 40%, and if you have an indwelling catheter is 100%. So a positive culture in this population really without an exam or assessment is not a UTI. You need to assess the resident for sign and symptom, and if they have no sign and symptoms, you really, first of all, you should not be getting a urine culture, because that's kind of drives the treatment, because it's very hard for us to look at the positive culture and not treat it. The other is, don't send it and monitor the patient, especially if it's really not clear what they have. And we know also some people say, oh, I can just treat it. It will help, from having recurrent UTI in the future. It doesn't really work. It doesn't prevent symptomatic episodes. It doesn't reduce the prevalence of bacteriuria. It doesn't, prevent anything chronic incontinence or improve survival, but it causes more harm. If you develop an infection afterwards, it might be due to a resistant organism, and you might have adverse effect from the antibiotic. Now, diagnosis, we don't really have universally accepted definition of it. What are the criteria that are used to define UTI and initiate antibiotic? And so there is a lot of protocol or algorithm that help the staff and the medical provider to assess if someone has a urinary tract infection or not, and if they should be tested or not. And I want to highlight that the updated McGeary criteria or the Stone criteria require, in addition to urinary signs and symptoms, the presence of a positive culture. And it's usually after the fact. It's very good for monitoring how often people are being tested and treated and how often they meet those criteria, but it should not be used to assess if someone needs to be treated or not. To assess if someone needs to be treated, you could use some of those algorithms that I have listed here. The law was first published, and it's a consensus statement of what constitutes urinary tract infection, signs and symptoms, and those should be used to assess if someone needs to be tested and treated. And I'll show you what these are. There's other algorithm, the Cernic algorithm, and the improving outcome of UTI algorithm, which I'll show in the next slide. Both of them really kind of focus on how can you identify who has a complicated infection, who has or a serious infection that might require transfer to the hospital, and who has a simple cystitis. So as far as criteria for a UTI that are used, and this is from the AHRQ website, and it's kind of a combination. It includes mostly the low criteria, and the criteria is different if you have someone with a catheter or without a catheter. So if you without a catheter, you're able to have dysuria, which is an important symptom of urinary tract infection. Alone, it might be enough to diagnose UTI. If you don't, then if you have fever, you need to have other urinary tract symptoms such as urgency, frequency, suprapubic vein, hematuria, or you have on exam some costovertebral angular tenderness, or you have urinary incontinence. And if you have no fever, you need 2 of those symptoms. For people with a catheter, and I would use that definition for people with dementia that cannot, tell you if they have dysuria or urgency or frequency, is to use more the systemic signs and symptoms of urinary tract infection to diagnose a UTI. So it could be fever, rigor, hypotension, worsening delirium, which is defined sudden onset of confusion, disorientation, dramatic change in mental status, or it could be an exam finding that are abnormal. So this is what I would use with patients with a catheter, because really they cannot have dysuria or suprapubic tenderness. They might not, or frequency. And I would use that for people who are, who have dementia or problem communicating their symptoms. This is the algorithm from the IOU, or the improving outcome of UTI, and it goes over kind of how can you differentiate between a plain cystitis or an upper tract disease, and what would you do if none of the criteria are present. And they really favor that you kind of observe the patient and monitor them and see if any sign and symptom develop. And monitoring is really still an intervention, because you probably would have to check more frequently the vital sign, you have to kind of hydrate, and you have to monitor more frequently the patient. And then what I wanted to see, so it is very important that we really, to be able to reduce the inappropriate treatment of asymptomatic bacteria, is to really reduce the inappropriate testing of the urine when someone has no sign and symptom. And this is an example from one of our collaborative nursing home in Rochester, New York, where we really work very hard on educating frontline staff and medical provider on, what are the signs and symptoms of a UTI, when should you check a urine. And we saw that with reducing the testing for urine infection, for UTI, we were able to reduce the treatment, overall treatment for UTI. So this is something that you might consider, to try to improve the treatment of urinary tract infection in the nursing home. As far as management of a UTI, it's very important to obtain a culture, especially that we are seeing more increase in resistance, that we're seeing a lot of extended spectrum beta-lactamase producing organism. So it is important to, before starting antibiotic, to obtain a urine culture. It's also important to obtain a good one. In many, for example, you probably need to have a catheterization in and out. It's important to explain to your nurses also that you have to remove an indwelling catheter before you get the sample. So obtaining that sample is critical, because if it's contaminated, it's going to kind of sometimes lead to overtreatment. Now, treatment, how do you treat? And it's recommended that it's based on an antibiogram. And if you have a small facility, you might not be able to develop an antibiogram. Locally, we were able to talk to our lab to get a citywide antibiogram for our nursing home that were less than 200 beds. And it was very helpful to see kind of resistance pattern. And I'll show you an antibiogram and show you how we made a decision to decide, in each nursing home, what should be their empiric treatment, what's the first line agent, what's the second line agent. It's important to also look at renal function to make a decision, at allergy and drug interaction. And then it is also important, once the culture comes back, to see if you could narrow the antibiotic, and it's important that the duration is very clear. So this is an antibiogram. I want to highlight, there's two circle things, that E. coli is really commonly the most common organism, and we're seeing more and more resistant to quinolones. So ciprofloxacin in this nursing home was only 65% sensitive. So quinolone are no longer the treatment of choice empirically for a cystitis. And so there are alternative. You could see that in this nursing home, trimethoprim sulfa for E. coli and all the other organism was about 80%. And nitrofurantoin has a very good activity against the E. coli Klebsiella. Of note, it doesn't cover Proteus. So if someone had Proteus previously, nitrofurantoin would not be a good option for them. So for this nursing home, we created the guideline that really pushed for using nitrofurantoin and Bactrim as first line treatment, followed by cephalexin, because the cefazolin also had a good sensitivity for the three most common organisms. And so I want to show you kind of, what are the first line, second line, and third line treatment. And this is based on the consensus statement from the AMDA Infection Advisory Committee. And it's similar to what I just mentioned. Nitrofurantoin is a drug of choice if the creatinine clearance is above 30. It used to be on the Beers criteria, but it is no longer on the Beers criteria. And we are really pushing that the nursing home to be kind of more familiar with its use and when it is and not indicated. It's definitely not indicated if you have pyelonephritis or upper tract disease. Trimethoprim sulfa use, it really depends. If it's less than 80% sensitive onto your antibiogram, it should really not be used empirically. Alternative includes cephalosporin, such as cephalexin. And the third is fosfomycin, which is, and you could use it as one dose. I prefer to keep it as a backup for resistant organism. It's approved for E. coli and Enterococcus, and we have good sensitivity even for ESBL against this antibiotic. And where I am, we are testing our isolates for fosfomycin. Quinolone, as you see, is now a third-line agent, especially for increasing resistance and adverse effect. This is alternative recommendation from the IOU consensus, and you could see it's similar nitrofurantoin and trimethoprim sulfa, but they favor ciprofloxacin and fosfomycin, and they use kind of the creatinine clearance as a way to decide what should be used empirically. Now, for upper tract disease, we favor that if someone has pyelonephritis, at least to give 1 dose IV, followed by one of those 3 agents, trimethoprim sulfa, if resistant is less than 20%. It could be ciprofloxacin or a beta-lactam. It's really kind of critical to look and see if they had prior urinary tract infection, if they had, for example, extended beta ESBL before, that you kind of are limited to what you could use in-house, and you might need to, if they're critically ill, to send them to the hospital. What I want to make sure is everyone is aware of duration of treatment. We are favoring more and more shorter treatment duration. For a lower cystitis in women, it's 3 days. For nitrofurantoin and beta-lactamase, it's 5 days. It's 7 days in men. For fosfomycin, it's 1 dose. For quinolone, it's 5 to 7 days. And for a pyelonephritis, especially if they get better, for trimethoprim sulfa and beta-lactam, 10 to 14 days, but it could be shortened if they get better, similar with a catheter-related UTI. So shorter is better. And so I will go next to the, respiratory tract infection. We are all familiar now with COVID, how common respiratory tract infections are. And I think it's important for people to understand what is bacterial and what is viral. So anything that is upper respiratory, such as, runny nose, sinusitis commonly is initially viral, and ear infection are viral. And the bronchitis are commonly viral. And it's important to differentiate between a bronchitis and a pneumonia. And the pneumonia, even a pneumonia we have seen with COVID, it could be viral, which is sometimes difficult to differentiate between viral and bacterial. And, sometimes we end up treating someone while deciding, if they have a pneumonia, is it really truly viral or bacterial? So it's important to educate your staff of, what could be potentially viral, what could be potentially bacterial. And for acute bronchitis, it's important to know that you can cough for 5 days, but you can cough up to 5 weeks, and your cough could be purulent. You could have sputum production, but there is really no evidence that treatment of a pure, viral bacteria, viral bronchitis, improve the outcome of the patient unless they have severe COPD. And for pneumonia, most of them are bacterial, but they could be viral. And they usually have elevated white count and abnormal chest X-ray. And so for treatment, for a bacterial pneumonia, it could be, you have to differentiate between bacterial and viral. And some patients are predisposed to have infection due to multi-drug resistant organism. For the bedside, what we should do, what should your nurses do to evaluate for pneumonia? Most of the people thought that if you had the pneumonia and you're older, you might not develop the respiratory signs and symptoms, but the majority of people will have cough, they will have shortness of breath, they have a respiratory rate about 25 per minute. Their pulse oximeter is, low, 93%, and they have abnormal, exam. So these are important to assess the patient. These are important to use for an S-bar so they can communicate to the physician or the nurse practitioner who's on the phone what are the signs and symptoms so a decision can be made. The workup, I think we should be testing everyone with pneumonia for respiratory viruses. We're seeing flu and RSV in weird time of the year since COVID started. We're also seeing, other viruses, parainfluenza. So it's important to, if you have more than one patient that's sick, that you test for viruses. A CBC might be helpful. A chest X-ray is helpful in comparison with prior, and if it's of good quality. The role of procalcitonin is unclear in a nursing home. And so I just wanted to show the low criteria. They're kind of difficult to follow. There's so many, but basically you have respiratory illness with some finding of a hypoxia or high respiratory rate, and that you should trigger you to evaluate the patient for pneumonia and to start antibiotic. Empiric treatment, we used to think about it, it's more, kind of what you should treat it like the hospital, but there's more and more evidence you should treat it what we treat with in the community. and leave the treatment for multi-drug resistant organism for people with severe illness if they don't improve or have other risk factor to have multi-drug resistant organism. So I want to show you what there's really no guidelines on what to treat nursing home pneumonia. We came up as a group in Rochester and made, kind of a decision how we're going to treat pneumonia in our facilities. And our first line treatment is oral, and it's cefpodoxime or amoxicillin clavulanate, and in mild disease, doxycycline. And the second line, we moved the quinolone to a second line agent. For severe disease, you have to, be cognizant, do you need to test for Legionella? We're seeing more Legionella this summer in our community. So that's something to keep in mind and treated. And we treat those for more severe disease, like we treat pneumonia in the hospital with ceftriaxone with doxy or ceftriaxone with izithro. Alternative would be unison plus izithro. And the second line treatment is quinolone. The duration, again, is short, 5 to 7 days, and depending on clinical stability, which are defined here, you should be improving before you stop the antibiotic. But again, it's short. So you can see the theme, nothing goes beyond 7 days, very rarely, if someone is improving. So quickly, let me talk about skin and soft tissue infection and highlight, kind of when should you, treat someone with a red leg or an ulcer, and when you shouldn't. And so a red leg is not always, or a red foot is not always cellulitis. There's other things that can cause a red leg or red foot, like gout, deep vein thrombosis, stasis dermatitis, lymphedema. And so it's important to know that, bilateral cellulitis is really not common. It should be a red flag that this is not cellulitis. And stasis dermatitis tend to be bilateral. It is very common in this population. It can really mimic cellulitis, but if someone has bilateral, has bullae, it has been kind of progressive over days, they really don't have much pain, no fever, no white count, this is probably just stasis dermatitis. And, you should not treat that patient with antibiotic. And this is a common misuse of antibiotic for cellulitis. Cellulitis, is usually acute. Patients complain that, they had, I have seen many that said, I started with rigor or fever, and then I noticed that my leg was red and painful. The cellulitis could be purulent and non-purulent, and that makes a difference because the non-purulent tend to be strep, different strep group A and B, C, and so the treatment would be different. For purulent, it is Staph aureus commonly. It could be MRSA or MSSA, but you won't be able to tell unless you do a culture, and it's recommended that you culture to make sure that can you change the agent and use a treatment for MSSA and that MRSA. And so for cellulitis, basically you need either purulence or you need warm, redness, swelling, tenderness, or fever, and these are the low criteria. And so what would you treat? I only included the oral regimen. If someone is sick enough that they need IV, they probably might be transferred to the hospital. So for non-purulent cellulitis, you target strep. And so anything that is penicillin, amoxicillin, cephalexin, dicloxacillin are the treatment of choice. For penicillin allergic patients, you could use clindamycin, but be aware that there's a risk of C. diff with clindamycin. For purulent, you should really cover for MRSA, so trimethoprim sulfa, doxycycline, and alternative would be linezolid. The other question I have, so what about ulcers? I have 3 pictures here, which one should be cultured and which one should be treated. You could see that both ulcers here really don't have much redness around them, no purulent discharge. And so these really should not be cultured, because if you're going to culture, you're going to recover an organism. This foot doesn't look good. You could see that there is a kind of erythema around this area, and it's kind of necrotic. This person needs to be cultured and treated. So again, don't treat ulcers. Even though this might look really bad, there's really no purulence here. There is no redness, and if the patient is not febrile, and you probe and you have no pus, you should not treat them. with antibiotic, you should not even culture them. And so for uninfected outfit that very commonly colonized, do not culture. You treat and culture if there is increased purulence, if there is increased warm, redness, swelling, and tenderness, and if they are febrile. And so this is all I have today for you, but I want to highlight it is important that to improve diagnosis and treatment of common infection in the nursing home to use the antimicrobial stewardship hat. It is important in our nursing home. The first thing they told me that they wanted is guideline. Please give us guideline what we should treat our common infection with how can I avoid the quinolone, what are alternatives. So creating the guideline and disseminating those guidelines is very important. Educating on what are the common signs and symptoms, how do you document them, how to communicate with the provider what they are is very important. And it is important, with all those organisms, sometimes they're not being used, and it is important to do a post-prescription review to see if the antibiotic can be stopped, if the duration is short enough, and if you can narrow the agent. And so I'm done, and I'll have Morgan tell you more about what you do with multi-drug resistant organism in nursing home.
Thank you so much, Dr. Dumyati. And I have to say, I am so impressed that you got all that into 30 minutes. That was a really awesome presentation. So thanks for.
So on the slide, I have some additional material that you could, look for, other guidelines. But let me stop sharing my screen so you could do yours. Okay, so. Cancel. Okay.
So I'm assuming you all can see my screen now. So I am Morgan Katz. I'm an infectious disease physician at Johns Hopkins. And I am going to really briefly talk to you today about thinking about the impending rise of multi-drug resistant organisms in the long-term care setting and some particular infection prevention interventions that have been done and what is going to be important moving forward. So again, my objectives today are really to talk about why infection prevention and stewardship can be so challenging in this setting, talk about some of the interventions that have been done, and then to really talk about the importance of engaging the facility in any of these interventions, be it stewardship or infection prevention. So why do we care about resistant organisms in this setting? First, we know that MDRO prevalence in long-term care is underreported and it is extensive. About 50 to 60% of residents are assumed to be colonized with a multi-drug resistant organism. And unfortunately, we are not aware of most of this because we're not doing active surveillance in this setting. Nursing home residents have multiple risk factors for colonization. They're going to and from the healthcare system, which results in regional transmission in dialysis centers, in the acute care center, and throughout the nursing home. And we know that more drug resistance results in fewer treatment options, and then more people die. So this is really important, not only for the residents in that setting, but also for public health. So unfortunately, long-term care facilities really do have infection prevention challenges at every level. And this really came to light, I think, in the setting of COVID. And we are really at a point that we need to start addressing this. So first, sort of on an individual level, you have healthcare workers that are dependent on staff for close personal care. This means feeding, bathing, all things that have high probability of risk of transmission of resistant organisms. They often have vague clinical symptoms, which results in antibiotic overuse, indwelling devices, which we know is a risk factor for infection as well as resistant organisms. They're going throughout the healthcare system, and residents in nursing homes are sicker than they have ever been before. And then on a facility level, you have limited resources with off-site diagnostic labs, high staff turnover, over 100% in many of these settings, this high resident to staff ratio. So one staff member may touch about 35 residents a day. And because of high staff turnover, it's really challenging to keep infection prevention education up to date. Prescribers are often off-site, which results in antibiotic overuse, and then these shared rooms and common areas, which certainly, as we've seen, can result in transmission of infection. And as a system, we have really failed the long-term care setting. Most of our policies and guidance is based on research that has been done in acute care. And this is really a very different setting, and we need to understand that better, and we just haven't done enough research to understand that. And there's just regional transmission on a system level as well. So a lot of my work in this setting has really been trying to understand the disconnect between the work as imagined, or the policies that we create, and the work as done, what they're actually being faced with in the day, these pitfalls that can make it challenging to do the do the work that needs to be done while following good infection prevention or stewardship activities. Again, our policies are largely based off what we know in acute care, and this is an incredibly different setting. So, our hospital setting, it's pretty easy to keep very sterile. You often have single patient rooms versus in a long-term care setting, this is often the patient's home. So they have all their belongings there. Many of the rooms, almost most of the rooms are double, some are as many as triple or quad rooms. So a lot of potential for transmission of infection and resistant organisms there. And you have this idea that we need to keep it looking like a home and not a sterile place. And so that results in limited access to hand sanitizer and other issues. So I'm just going to briefly touch on two potential on horizontal interventions and vertical interventions as infection prevention interventions, and then talk about what we know in this setting for those interventions. So just to review, horizontal interventions are infection prevention interventions that are not directed towards one particular pathogen. They really aim to prevent the spread of multiple organisms simultaneously. So these are things like hand hygiene, environmental cleaning, and antibiotic stewardship. These are generally more cost-effective and also more effective in the long-term care setting. So vertical interventions are aimed at a single pathogen. These include doing active surveillance to look for a particular pathogen, and then targeted decolonization for people that are colonized, or implementing contact precautions for specific organisms. Again, this is much more challenging in long-term care. We're really not doing a lot of active surveillance due to resource limitations, but it's great for outbreak management. So things like Candida auris, you would want to implement vertical interventions. What's important to note here is that we must have our horizontal interventions intact before we can see any success with vertical interventions. So I want to touch a little bit more on some of those horizontal interventions now. So hand hygiene. Unfortunately, hand hygiene compliance in nursing homes is generally pretty low. Before the pandemic, observational studies cited it at about 15%. After the pandemic, we're up to about 15 to 58%, so did see some improvement there, and some of that may have been due to the increased availability of hand sanitizers in the setting of the pandemic. But still, staff think that they're washing their hands. This recent study looked at staff's self-assessment of hand hygiene compliance, and it was 91% versus when they actually observed the staff, which was only about 17%. And there's various barriers that may decrease compliance to hand hygiene. As we've talked about, this limited access to hand sanitizers. And then there's a belief that gloves can substitute for hand hygiene often in this setting, and that is just simply not the case. And, what you'll see me emphasize throughout this presentation is how important any intervention is really getting buy-in from the facility to do these interventions. That means trust, that means helping them understand why this is important. So this is just an example. These are 12 facilities that we partnered with during the pandemic to help them improve both PPE and hand hygiene practices. We set up a hand hygiene monitoring system within the facility. And what you see here is that in the engaged or high-performing partner sites, we saw a really nice increase in hand hygiene compliance throughout the course of the intervention versus all the sites, many of which were not engaged for various reasons, and much of which was because they were completely exhausted during COVID. But these sites you didn't see a huge increase. I will note here that our hand hygiene compliance rates were great and better than what we've seen in most of the literature overall. So moving on to environmental cleaning, this also is an area that really hasn't had enough research in this setting. One recent analysis looked at high-touch areas in long-term care across 11 nursing homes, and they found some type of fecal contamination or organic debris on over 90% of surfaces on high-touch areas. We're actually doing a study now looking at the specific barriers to environmental cleaning in long-term care. And some of these are, as I've said before, the resident belongings, hard to move all of their stuff, to clean under it, often poor delegation of tasks, and then education about contact times and specific cleaning products, again, is very hard to turn over with staff changing so often. Unfortunately, a recent review looking at 6 cluster randomized controlled trials just targeting environmental cleaning education really actually found that only 2 out of 6 of those interventions resulted in a reduction of MDRO prevalence. So environmental cleaning education alone does not seem to be enough in this setting. And so now let's touch a little bit more on antibiotic stewardship. So we all know, and I've sort of touched on the fact that there are many unique challenges to implementing and sustaining stewardship programs in this setting. As Dr. Dumyati said, over half of all prescriptions used in nursing homes are not considered concordant with guidelines. And most of this is because the stewardship programs are still working on getting developed. They often rely on one individual who has a lot of things to do. It's often shared with the infection preventionists, and they don't appropriately empower the direct care staff to critically think about antibiotic prescribing practices. We know that overuse of antibiotics leads to resistance and will actually change the microbiome of the individual resident. So giving multiple rounds of antibiotics really selects for these resistant organisms. And we know that residents in long-term care facilities are getting exposed to antibiotics frequently. There's also recent data that's showing that what's happening in acute care is actually impacting nursing home residents. So it's not only on the staff or the physicians or nurse practitioners in the nursing home setting that are prescribing these medications. This was a nice study that came out in JAMA Network Open that looked at skilled nursing residents that were discharged to a skilled nursing facility from the hospital. And what they found was that 58% of them had gotten some type of antibiotic within 60 days of enrollment in the study. 96% of those antibiotics were hospital initiated, and 43% of those were high risk antibiotics. So a lot of these antibiotics in these skilled residents is coming from a prescription in the hospital. And we clearly see a link between this exposure to antibiotics in the hospital and their risk for MDRO colonization. So pre-enrollment exposure was associated with an increased risk of MDRO colonization and even higher risk in those that were exposed to high-risk antibiotics. So we really need to understand that on the acute care side, we also share the burden of this antibiotic prescribing. So I do want to introduce a really nice antibiotic stewardship toolkit that is now free and publicly available through AHRQ. Which we just finished developing a year or so ago. And again, this program is really designed to talk about some of these core topics to emphasize the importance of resident safety and involve the direct caregivers into thinking about this prescribing process. There's a whole lot of content on there, toolkits, tells you how to establish your program. So if you're looking to get your program together, this may be a nice outlet for that. And the idea of the program is focus a lot on these 4 moments of antibiotic prescribing. So the first moment is, does the resident have symptoms to suggest an infection? This is one of the biggest, as Dr. Dumyati said, this was sort of one of the biggest challenges that we have in long-term care, is really deciding if this is even an infection at all. And we sort of walk you through those steps and understand other things that could cause some of the symptoms the residents may be having. And then if we decide it's an infection, what type of infection is it? Have we done the appropriate diagnostic tests, and what therapy should be initiated based on the infection? And then we talk about how long antibiotics should be so that there is a clear stop date on any antibiotic course, and this very important antibiotic timeout prompts even direct care staff to make sure that they're reevaluating the resident as diagnostic steps come through, understanding that they can either stop antibiotics or narrow them if indicated. And again, sort of this tune that I keep bringing back to you is that results of this study really showed the importance of engagement. So we really saw a stepwise improvement in reduction in antibiotic use in the facilities that were actually going to the webinars and were engaged in the program. So you see even a small increase in antibiotics in the facilities that didn't go to any webinars, and then a nice reduction in facilities that were engaged. So just to touch on evidence for vertical interventions in long-term care, there isn't a whole lot of evidence for this now because active surveillance is really rare, and most of our colonization reports rely on what we know from surveillance that's done in acute care. Lona Modi did a nice cluster randomized trial using active surveillance and chlorhexidine bathing for high-risk residents, which was a huge endeavor and did show a reduction of MDRO prevalence in the patient's environment, but we didn't really see any change in patient level factors. So still haven't figured out exactly how to implement these vertical interventions with the resource limitations in this setting. It's also pretty difficult to determine an endpoint for decolonization. In surgery, it's often easy to decolonize prior to surgery, but with residents that are staying in the facility for years and years, there's always a risk of recolonization and needing to decolonize them again. So this was a really nice systematic review of the studies actually doing these multi-component interventions targeting MDROs. This one's looking at MRSA colonization. And as you see, there's really no rhyme or reason based on this to which interventions work and which combinations work. However, what they found is that there were no significant differences with any of these interventions, and the ones that were successful were the ones that had administrative engagement. It really is crucial for any effective program, and this is where we need to start before we can initiate some of these more complicated infection prevention interventions. So how do we make it work? We know that without an engaged workforce, interventions will be futile. We know that staff turnover, limited buy-in from leadership, and staff feeling undervalued or not understanding their role in the intervention can lead to a reduction in engagement. We also know that staff that are still working in this setting after the last 2.5 years are likely doing it because they care about the residents. This is not an easy job. In fact, I would argue it's one of the hardest jobs there is. And so interventions have to be resident-centered and tangible and understandable to the direct care staff, because these are the things, they're the ones that are going to be expected to do some of these activities. And acute care needs to share the burden. This isn't only on long-term care. Our prescribing practices, our communication, our infection prevention practices do impact the nursing home residents. So just some final core concepts to improve infection prevention and stewardship in this setting. Thinking about starting to incentivize more research in long-term care. If you work in long-term care, consider welcoming an academic research team in. We can only do better if we can learn from you. Valuing and engaging direct care staff so that they want to be part of these interventions. And finally, the leadership need to make sure to provide the resources and the regional oversight to do the work. We have one silver lining to COVID now, and that is that infection prevention and long-term care is under a spotlight. We can expect more funding and resources dedicated to this cause. And the staff have really seen the consequences of lapses in infection prevention in this setting. So they hopefully will understand more why this is so important. We also have staff that are more comfortable with PPE and basic infection prevention practices probably than they've ever been before. So this is my last plug to double effort and ensure that changes continue here. So that's all I have today. Thank you so much for joining.
Well, thank you both so much for your presentations. We learned so much and really appreciate you guys presenting today during our summit. So if anyone has any questions, feel free to put them in the Q&A box on the right-hand side of your screen. If you click on the session tab, you can click on Q&A to submit their questions. There's a handful of questions that people have been adding. Dr. Dumyati's answered some of those for us. So I'm not going to read through those, but I am going to highlight this one that Jamie had shared. Why are we referring to post-pandemic when we're still struggling to reduce the incidence of COVID-19? So appreciate your comments. Oh, Dr. Katz, you're on mute.
That's a great comment, and I'll agree. I mean, we can't really say post-pandemic at all. I would say post-emergent stage of the pandemic when we didn't have a good understanding or resources. But you're right, it is not post-pandemic. I think we're moving into the endemic stage now, so that's where I sort of decide to move into post-pandemic, but I know it is still challenging.
Can I add something? I noticed that I didn't mention, I missed a slide about the duration of treatment of cellulitis. I just want to make sure that it's short. It's 5 days for, kind of a regular non-purulent. It's probably 7 days for a purulent. And for people to understand that, kind of redness stays, the leg stays red. What we assess when we assess response is more like, did they have a fever that went away? Did the white count improve? So the redness might take much, much longer than the 5 days we treat. And I'm sorry, I kind of missed that slide. There are some questions, and I think a lot on UTI. So maybe Jenny, do you want to read them, or shall I?
Yeah, I know there's a handful about different signs and symptoms to look for. There was a question about signs and symptoms for nonverbal patients and some criteria for how long to give therapy. So feel free if you, to add some comments or to tackle those.
So I responded, for someone who is nonverbal and you're trying to assess if they have a UTI or not, it is really suggested that you use what I would use for a catheterized patient. Rely more on sign and symptoms of, kind of a more severe disease. Did they have fever? Did they have tachycardia? Did they have tachypnea? Did they have, other hypotension, other things that make you think they might have an infection? Morgan, you can add to it, but it is, and then you could monitor them if they don't have any of those warning signs. Monitor them and see, if they get better or not. I think we are treating a lot of people because, you know, they're confused or we cannot get the history. And what we're trying to avoid is over treating and maybe more monitoring if they're stable, basically. So there is one, I think there is one from Tracy about, I work in the long-term care, and when residents have a mental status change and we do a urinalysis and CNS, this is what you should not do. It might show that they have a GTI. It might show that they have a positive urine. So why isn't it a mental status symptom? Because there are times there are not other symptoms after receiving the antibiotic, the result becomes stable again. It's a very common question, and I think we have learned that if you probably this person that is confused for dementia, they have good days and they have bad days. So if they're confused today and you waited a little bit, monitor them. If that's the only thing that they're presenting with, they might be better tomorrow. You might attribute it to the antibiotic, but truly it's not. You know, you should use it though in catheterized patient. That could be like delirium is a sign, but in a person that's not catheterized, and if this is the only thing they have, they don't have anything else, it's really recommended that you don't test their urine, and you don't treat them. And, you know, Morgan or Raj, do you want to add?
Yeah, thank you, guys. I was just wrapping up another presentation, so everyone, Suraj, Mahaj, and I'm going to just be here, fly on the wall. I can't, you know, I've got some great minds and great, you know. Thank you for coming, Dr. Katz and Dr. Dumyati. It's just really extreme pleasure and honor for us to have you on this. Not waste my time. I just want to do one comment on that. I think the question from Tracy is, why is mental status change not part of the criteria? And I think we can speak to the work that Stone et al. They did in 2012 in updating the McGeer criteria, where everything was published. And so just on the evidence that was reviewed. So if you guys can just comment to the fact that why we have all those 5-6 things in there, but not mental status change. And so that I think that really can answer some of these concerns here. Dr. Katz, are you trying to speak?
Sorry, I didn't know if Dr. Dumyati was taking that. So yeah, you know, I think that this has been studied, and we have very clear evidence. First of all, in terms of
Dr. Katz, we might have lost you. Oh, there you go.
can you hear me?
Yes.
If you want to repeat, so yeah, we lost you for a second there. Yeah.
Oh, sorry. So without any, do you want me to start from the beginning?
Mm-hmm.
Sorry. So without any other evidence of changes in their clinical symptoms, there really has been no evidence that mental status change alone is enough to, is diagnostic of a urinary tract infection. So, you know, in my opinion, a lot of times it really is tincture of time. So making sure that you closely monitor the resident and look for any other potential signs and symptoms, and hold off on antibiotics even for 1 to 2 days is recommended at this point.
Thank you, Dr. Dumyati. Would you like to comment on, because I think this is really where the actual users in the field, the clinician, tend to disagree with recommendations, because they do anecdotally see that, where if the UA was ordered because of mental status change, and we talk about this a lot with older adults and dementia folks that are not able to voice some of the pain and related things that are on that list, and the fact that for folks that get treated, they get better, right? And so I'm trying to be, on that side, trying to, there is some discontentment with some of the expert things where I just asked that question on the acute care side where, with the early on signs and then next thing you know, they're in full-blown sepsis and going to the hospital and the question only if we have started antibiotics, early on. So what we are trying to say here is that there was all the evidence reviewed when the criteria were reformulated back in 2012 and updated later. And so what I say is that that one evidence or one instance when things got better sticks to your head, but all those times where antibiotics were used unnecessarily, it just doesn't. And so thank you very much. I think those are difficult questions and must be asked, and having experts kind of weigh in on that. So it's purely, I don't know how many papers were reviewed when they came.
Yeah, Raj, there is a new document that was published by Dr. Rowe that is in my presentation about kind of the non-specific sign and symptoms, which one of them really, are possible infection. If you have mental status changes with a fever and a, tachypnea and tachycardia, that's different from just having mental status change or confusion alone. So you really have to assess and make sure that you're not missing something, because it could be, one of many sign and symptom that the person has.
Yeah, thank you for that. And then I think some folks are interested in slides. It's my understanding all the slides will be available after the sessions, so you will have access to the slides.
Yeah, and I want to comment about the families and pushing for treatment. Education is important to treat without it takes a lot of time to spend with the family explaining why, their loved one should not be tested for UTI and why they should really, we should not treat with antibiotic. I think when I sit there and take the time and explain what the risk of antibiotic in this situation, C. difficile, resistance, kind of more side effect, they're and that the fact that I'm going to monitor their loved one, I think they might be more, willing to accept to just, do, observation and not treating with antibiotic. And I think we're beyond our time, right?
Yes, no, I appreciate all of your comments. Yeah, we are at the end of our time. Our next session is going to start at 3:45, so we have a few minutes. There were a couple questions that were still in the Q&A, so we can gather all of those and then share them with Dr. Dumyati and Dr. Katz and get some responses as well. So thank you so much. We truly appreciate you sharing with us today.
Thank you for inviting us to speak.
And I echo Jenny's gratitude. Thank you. Our group is very, very appreciative for this. Thank you.
Yeah. Thanks. Bye.